I'm the manager of the research department, and I'll be filling in for Alan for the remainder of this session. We'll start off our session talking about emerging issues, and we will begin with our presenter, Dr. Michelle Mccarron, who is a research scientist with the Saskatchewan Health Authority and is an adjunct faculty member in psychology at the University of Regina. Michelle received her PhD in experimental and applied psychology from the U of R in 2010. She has expertise in qualitative and mixed methods research, and her primary areas of research interest are biomedical and research ethics, as well as public safety, personnel, and frontline healthcare workers in mental health. Please join me in welcoming Michelle Mccarron in sharing with us her presentation on experiences of moral injury in Saskatchewan's frontline healthcare workers during the COVID-19 pandemic.
Great, thanks, Sandy.
Thank you.
Hi, everyone. As Sandy said, my name is Michelle Mccarron, and I'm a research scientist with the Saskatchewan Health Authority's Research Department. And I'm going to be speaking with you today about the topic of moral injury in frontline healthcare workers, and I'll get into what that term means in a moment. But first, I just want to quickly acknowledge the other members of the project team. Dr. Olu Hassan and Fiona Fick are my colleagues in the SHA Research Department, and our research assistant this summer, Yusuf Omar, is now a first-year medical student at the University of Saskatchewan. From the SHA, we also have Dr. Brandy Winquist, Executive Director of Academics and Learning, Dr. Melody Eisinger, Director of Ethics, and Donna Milo, Mental Health Strategy Specialist for Emergency Medical Services Provincial Programs. We also have two co-investigators from the University of Regina, Dr. Amber Fletcher and Dr. Nick Carlton, and from the University of Alberta, Dr. Lorraine Smith-McDonald and Dr. Suzette Bermeau-Phillips. This research was made possible by a grant from the Canadian Department of National Defence Ideas Program, and also received in-kind support from the Saskatchewan Health Authority. This study was approved by the SHA Research Ethics Board, and I have no conflicts of interest to declare. Finally, before I begin, I would like to acknowledge that I am presenting to you today from Treaty 4 territory in Regina. So, as I mentioned earlier, the topic of our Sorry, it looks like I got muted there. So as I mentioned earlier, the topic of our study was moral injury among frontline healthcare workers. While this is a fairly new term within the context of healthcare, what it represents is certainly not new. Moral injury is the physical, psychological, or spiritual harm that can occur when someone is in the position of having to do things that run counter to their deeply held convictions, or if they witness something happening that they recognize as being morally wrong, but they're unable to prevent it. The concept of moral injury originated in the military, specifically in research with Vietnam War veterans. There's been a lot of research about post-traumatic stress disorder with this population, but moral injury was identified as a distinct issue because it's possible for an experience to be traumatic without violating someone's moral convictions and vice versa. Within the past 10 years or so, this concept of moral injury started to take hold in research with public safety personnel, mainly with police officers at first, and within the last 3 or 4 years in particular, it's really gained traction in other areas as well, including with frontline healthcare workers. A term that might be a lot more familiar to people in healthcare is moral distress. A lot of what we know about this comes from nursing research, and this dates back to the 1980s, so well before the research on moral injury with military veterans began to take shape. Moral distress is what someone can feel when they recognize in their minds and their hearts what is the morally correct thing to do, but there are barriers in place that are preventing them from doing it, or that require them to engage in something that they truly feel to be wrong. This can include a whole host of obstacles, many of which can be systemic. An example could be having to tell a patient who requires cancer surgery that their treatment needs to be delayed because the system is stretched beyond its capacity. So essentially, moral distress is what someone experiences in those moments. and moral injury is the longer-term impact to someone's mental, physical, and spiritual well-being when they have those types of experiences. The COVID-19 pandemic has brought about scenarios that are unprecedented in terms of both the types and the volume of experiences, where healthcare professionals may be faced with making very difficult moral choices and have to do things that they don't necessarily feel are right. The aim of this study was to better understand the experiences of moral injury among frontline healthcare workers, particularly within the context of the pandemic. One of the objectives was to better differentiate symptoms of moral injury from those of PTSD, and that's the stage that we're at right now in terms of our analyses. So I'm going to be focusing today on our other findings about the nature of the experiences people shared and the types of symptoms in general that they reported following those experiences. We conducted one-on-one interviews with 37 frontline healthcare workers from a variety of fields across the province in late June and July of this year, so before we actually got into the worst of it with the fourth wave. We began with a combination of purposive sampling, which involves things like deliberately seeking out people from a variety of roles within the healthcare setting, and snowball sampling, or word-of-mouth recruitment. In order to spread our reach further, we ran a story in the SHA Daily Rounds newsletter to seek volunteers for the study as well. We used a constructivist grounded theory approach, which in a nutshell involves starting with line-by-line coding to identify very specific variables, and then finding the ways that they link together, ultimately culminating in the development of a more comprehensive theoretical understanding of the concept being studied. In terms of reporting on work-related demographics, we're keeping these fairly broad in order to minimize the risk of participants potentially being identifiable. So there were 13 participants who worked in hospital settings, 12 were in long-term care, 6 worked in the areas of public health and primary health care, and 6 worked in other types of healthcare settings. 11 participants were in nursing professions, 8 worked in the areas of recreation therapy, physical therapy, or occupational therapy. 5 worked in mental health related fields. 4 were physicians, and 9 people were in other types of roles, such as various support services. The majority of participants were in Regina or Saskatchewan, but we also had 6 participants from northern regions and 6 from central and southern rural communities. There were a lot of factors that contributed to people having negative feelings about their work. Some of these were internalized, such as finding less meaning and purpose in their work. Other aspects were more tied to things pertaining to organizational culture and systemic constraints, such as feeling a lack of autonomy in their role, not feeling heard or that it was unsafe to express their concerns, not feeling appreciated, being under-resourced, and not having the support that they felt they needed. People often experienced a combination of moral dilemmas, which are those internalized conflicts, and situations where they felt that what was being asked of them clashed with ethical codes of conduct. A common situation that resulted in moral distress, particularly in long-term care, had to do with family visitation policies, especially around Christmas. Several people indicated that while these policies were intended to protect people physically, they were nevertheless causing psychological harm to people. There was a physical toll that these types of experiences took on people as well, the most common being exhaustion, insomnia, headaches or migraines, and body aches. There were also some physical symptoms that were secondary to other things, such as weight gain and other effects of decreased physical activity, but it was difficult for people to attribute the extent to which that was related to their experiences of working in healthcare during COVID versus the impact that restrictions were having on people in general. People also spent a lot of time talking about the impact that all of this was having on their mental health. People who weren't normally prone to tears found themselves crying more easily and more frequently. People were finding that they had difficulty disconnecting from their work at the end of the day and were spending more time worrying about their patients and residents when they were off the clock. Several people described feelings associated with anxiety, and some were fearful about the future, such as what the impact of all of this would be on the healthcare system long term. People described feeling broken, this sense of helplessness, sadness, and guilt, which sometimes culminated in things like feeling emotionally detached and less motivated. Going back to that example of visitor restrictions, one participant described her experience working in a long-term care facility around Christmas time last year. She explained it like this. So basically, we would push residents up to the window and we'd open the window, and it would be cold because it's the middle of December. So we covered them in blankets. And then family would be standing outside freezing and scream at the window, "I love you." And it's like, I'm just watching there by the desk and I was crying my eyes out because I can't imagine if that was me. If I was alone in a place, I was sitting in a place where everybody were strangers to me because they're not my family, and be excited about the fact that it's Christmas and that means I get to see my family. But then this young girl working here would tell me that I can't see my family. And that's the best they can do for me, basically to have them scream at me through a glass window. People often reported feeling isolated and withdrawing from others at times, but they were often unsure to what extent, again, this had to do with moral injury versus the general social impact of COVID. One interesting finding is that, unlike with the military research, the spiritual impact to people often did not have anything to do with their pre-existing religious beliefs or lack thereof. Rather, it was a loss of faith in humanity. Things like vaccine misinformation being spread by people on their Facebook feeds, people refusing to wear a mask in public, or people protesting or violating public health orders seem to hit particularly hard for people who see the impact of COVID every day and are worked to the point of exhaustion because of the ongoing pandemic. However, people also found glimmers of hope that helped to restore their faith in humanity. One person shared a story from when the first vaccines were starting to be distributed. They said they were doing AstraZeneca at the drive-thru, and this was not very long after all of the, "oh, nobody wants to get the AstraZeneca." And I drove past and there were cars lined up and I just started to cry. And I can't even really identify exactly why I was crying, but it was just, I think, a kind of sense of relief that people are still going, even though there's all of this controversy, if you will, around it. Yeah, and just maybe like a little bit of happiness and just like a sense of, we're still going to get through this. But then afterwards, I was like, well, that's probably not a real normal reaction. Like the average Joe probably doesn't drive past the drive-through site and start crying because there are people getting vaccinated. But then when I was talking with friends of mine who work in healthcare, they have the same reaction. One of my friends told me that they can see the drive-through from the windows of the hospital and they go on break, and that's what they do. They just stand and watch the drive-through and just monitor how many people are going. There were a lot of organizational and operational types of challenges that people experienced, and we don't have time to dive too deeply into these today. But in general, they came down to concerns about the impact on the quality of patient care, human resources and capacity issues, leadership approaches, and communication. Related to that last point, one of the things we heard is that while there are some supports in place, it's very difficult to strike the right balance. There's a very real danger of inadvertently compounding the effects of moral injury if the types of support and the messaging are framed in such a way that people infer that they're being told that it's essentially through some failing of their own that they're feeling the way that they are, and that the responsibility for fixing it lies squarely on their shoulders. One participant said, "That's all great to put it on paper, but the problem is that we actually have to practice what we preach, and we aren't. We aren't practicing what we preach. I just think that in order to practice resilience, you can't just put it on paper and say, here you go. You actually have to give people the time to do it. And they have to be in a mental space to do it, not working 10-hour days." Another person said that we can do a lot of things that definitely help our mental health, right? Like exercise and eat right and all those things that somebody will tell you. Then somehow somebody has decided that it is our individual responsibilities to do all of those things and take care of that, which it is. I can't argue with that, but nobody does anything about our environment. So I just want to share some final thoughts to summarize what we've learned so far and where we can go from here. First of all, I would say that the main takeaway from all of this is that healthcare workers are hurting right now. They're feeling the physical and psychological effects from the types and volume of morally distressing things that they're experiencing. This could have some grave implications for the well-being and sustainability of our healthcare workforce, which could ultimately have huge implications for patient care going forward. There's a lot of work left to be done in order to address moral injury among healthcare workers and the morally distressing situations that are at the root of them. And I just want to conclude by reiterating that further research in this area and the development of strategies for addressing this issue need to have direct input from the healthcare workers themselves who are facing this every day. Because at the end of the day, they're the ones who know best what problems they're facing, and they have an in-depth understanding of the issues that need to be addressed in order to alleviate them. I want to end by giving my sincere thanks to the people who participated in this study and shared their stories, and to everyone working in our healthcare system who give so much of themselves every day. And now I'll turn things back over to Sandy to see if there are any questions from the audience.
Thank you so much, Michelle. This was such a interesting topics, considering that we're living in the fourth wave of the pandemic. I was really touched by that story of the nurse in long-term care facility. You're right. We all think of ourselves like, what if we were in that position? But I really like the fact that people drew on the positive as well, not just dwell on the negative. I quite appreciated that. And I think we're all very happy to hear when the vaccines were rolling in at the beginning of the year. And now that we are, it's available, and about 80% of our population is vaccinated. But obviously, we need to support our staff as we're going through this. Thank you so much. I'm just checking in the chat here. There's a comment and a question from Shabrandu from our research department and the SHA, and he thanks you for a lovely presentation. Based on your interviews with frontline healthcare workers, what are the potential risk factors for moral injury?
So that is kind of where we're going next with this, actually. So in kind of distinguishing between those symptoms of PTSD from moral injury, one of the things that is kind of a next step with this is that there aren't really a lot of tools for screening for moral injury in frontline healthcare workers. There are some, again, from military and a little bit being adapted for healthcare, but with the ones with healthcare, they are almost exclusively American and have questions in them that are very based in the American healthcare system, so not necessarily appropriate for working with Canadian healthcare workers and trying to screen for that. So that is one of the next things that I want to look at, actually, is to, as we better differentiate that and pick apart those the symptoms that are specific to moral injury in particular, to look at potential development of a screening tool.
Thank you, Michelle. I think we only had that one question, but if there are other questions, you can definitely look into the chat box later on. Thank you, Michelle. I'll just move on to our next presenter. Thank you, Michelle. Yash Tendulkar, who is 25 years old and working on his Bachelor of Arts Psychology degree at the University of Saskatchewan. He hopes to have a career as a counseling psychologist working with adolescent and youth going through Canada's criminal justice system. He has a lofty goal that like making a difference in his community while also securing a job that allows him to stay above the poverty line. These days he works part-time in the kitchen at the LTSC home in Saskatoon. He also is a certified yoga instructor and would take personal courses prior to the pandemic. Would like to take, personal classes. On the weekend, he volunteers at the Friendship Inn here in Saskatoon, which helps provide free meals for anyone in need. Thank you so much. This would be very interesting to hear your presentation today with us. If you'd like to share your screen, just begin. Your presentation is on experiences supporting video conference visits during the COVID-19 pandemic in rural Saskatchewan long-term care homes. If anyone would like to also have questions in the meantime, please post them. Thank you. And I'll hand it over to Yash.
Hi, everyone. I didn't actually know that bio was going to be read out loud, but Cool. All right. Let me just get my notes and stuff. All right, so morning, everyone. My name is Yash Tendulkar, and I'll be presenting our research on the impact of supporting video conferencing visits during the COVID-19 pandemic in Saskatchewan long-term care homes. So a little bit of background information. During the pandemic, residents at long-term care homes were not allowed in-person visits by family and friends. Instead, distance communication methods were implemented. The responsibility of facilitating this sort of communication was put upon the Recreation Department to be done alongside their pre-pandemic responsibilities. Research from earlier on in the pandemic told us that this significantly affected the quality of their work. Talking with research partners, we learned about some of the technological challenges rural long-term care homes were having providing certain forms of distance communication. From family caregivers, we learned that some residents with cognitive impairments like dementia were having a hard time getting any value out of the provided methods of communication. The purpose of this study was to understand recreation team members' experiences in providing distance communication and their take on its effectiveness. For our research study, we collected data from 4 long-term care homes in rural and northern Saskatchewan. The data was gathered through individual interviews via WebEx, and the interview questions centered around methods of communication between residents and families, experiences and challenges with coordinating and facilitating family visits, quality of remote visits, general working conditions, and the availability of technological resources. Detailed field notes were taken after each interview, and a rapid qualitative description of field notes was completed to support early dissemination of results. A theory-guided deductive qualitative analysis will follow. What I present to you today are preliminary findings from those field notes. Our study found the 4 most common methods of distance communication in order of popularity were outdoor visits during the summer, phone and video visits, window visits, and letters. Outdoor visits were the most popular, of course, as you could see your loved one sitting across from you. They only happened during the summer. Phone and video visits were the most commonly used form of distance communication. They were easy to set up, but difficult to execute. Window visits allowed for residents to see their families from inside the long-term care home, while families stayed outside. Unfortunately, planning and facilitating window visits was difficult. One of the basic issues just being the layout of the home and whether or not people have windows in their rooms. Some of the barriers for quality distance communication were the scarcity of data plans, lower quality internet, and resident readiness or ability to learn how to use newer technologies. Unfortunately, data plans were not available for all residents. Those who didn't have a phone or video call capacity on their own to rely on the facility's Wi-Fi, and low quality internet connection was identified as an ongoing issue in a number of facilities. Recreation team members perceived that residents had varying reactions to utilizing the technology, and this depended on cognitive ability. Some residents had no trouble picking up on the skills needed to phone or video call their loved ones. Others needed recreation team members present during the whole conversation to assist with the call, and still others were unable to understand or simply just didn't want to try. One of the interviewees recalled an elderly lady who fell into the 3rd category, who said, "What's the point of showing them my face? I don't look any different." Overall, telephone call and video conferences were perceived by recreation team members as less adequate for meeting residents' social needs compared to in-person contact, but they agreed that this was the best method given the current pandemic situation. Some factors that improved the quality of distance communication was community donations of data plans, phones, and tablets, shared responsibility of supporting distance communication, and the regular presence of the long-term care home manager at the home. Communication was supported by local communities and charities through donations of iPads with preset data plans, tablets, and phones. These donations allowed for a higher quality of communication and allowed the residents to keep in touch with family and friends from the comfort and privacy of their rooms. Shared responsibility for supporting virtual communication was a huge help, according to recreation team members. In one of the long-term care centers, the nursing staff would regularly assist recreation team members ferry residents to and from meeting rooms and assist residents with their phone and video visits. This was a huge help to recreation team members, as it allowed for them to focus on other aspects of their job and made them feel like they were part of a cohesive team. Having the manager of the long-term care home in the building was also identified as important. There were dilemmas about working on site when it was not absolutely required, but it was a huge moral boost for the recreation team members and staff in general to just see their manager come in to assist and work with them. It also allowed for faster policy implementation and troubleshooting, as they were the ones with the knowledge regarding policy. Some of the biggest impacts of infection control policies for the Recreation Department included an increase in the scope of duties for the Recreation Department, resident group size reduction for recreation activities, and an inability to recruit volunteers or outside help. Recreation workers were asked to assist with coordinating family contact by video, outdoor, by telephone, and at windows on top of their regular responsibilities. This meant that they had to schedule meetings, bring residents to meeting rooms, be present to assist with any technical issues, sanitize the location after meeting is done, and then bring residents back all on their own. The extent of collaboration with other staff on this varied. For example, care assistants were asked to help residents to be up and ready for the calls, and sometimes screeners would help with scheduling visits. At one home, even though recreation team members took primary responsibility for resident family communication, nurses chipped in to help whenever possible by being present during the actual meeting. These forms of collaboration made a significant difference in recreation team members' sense of support, teamwork, and job satisfaction. A reduction in resident activity group size meant that recreation team members had to do the same activity a lot more times and to come up with a lot more types of activities. This, as it's clear, would take a lot of time out of their day. Being unable to recruit volunteers or outside help meant that team members that were working that day had to do all of the activities themselves. Usually, the recreation team would bring in pastors or musicians or other activity directors to brighten up the residents' day, but they were unable to do so during the pandemic. Overall, the shortfall in available hands-on deck was perceived to impact quality of care, recreation programming, and timely, regular contact with families. For more information on this point and a resident perspective on this whole situation, I would recommend that you go check out Kylie Lorenz's poster at this conference. Many interviewees mentioned that they didn't feel ideally suited to this role. Although they recognized that this was a very important job, they questioned why this work was assigned to them. Recreation team members often describe themselves as responsible for creating an atmosphere of relaxation, fun, and joy. Since it didn't quite fit into the scope of their previous work, they didn't feel like their skills were well matched to facilitate family-resident communication. Staffing issues was a common theme in the interviews. One of the questions that I asked the interviewees was the current number of staff working at the Recreation Department and the ideal number of staff that the department needed to run things smoothly. Almost always, the ideal number was higher than the current. In rural areas, the total number of recreation and care staff is lower than that in cities. It's not uncommon for staff to work casual or part-time hours at more than one site. Staff cohorting policies reduce the number of employees available to each site, and this felt to be a particular issue for rural contexts because of labor shortages. This issue, along with reduced availability of family and volunteers to assist and altered work demands, increased work burden and required use of overtime hours. Using up the budget with overtime hours meant less money to hire extra casual or part-time workers. We believe if there was an opportunity to hire even at a lower experience level, this might have helped relieve the situation. This study has shown us that there are still aspects of distance communication in long-term care homes that need to be explored. Some of those avenues are mentioned here. Recreation team members' perspectives suggest that additional study on the experience of video conferencing visits from a resident and family point of view is needed. There's also a very significant need for research to explore how well video conferencing and telephone calls supported residents with dementia and how this experience could be adapted and improved upon. Staff and manager perceptions suggest that internet infrastructure and staffing levels were not as adequate for supporting residents and family communication during periods of stringent infection control. One of the solutions offered to us was to invest in additional routers or alternate internet packages to higher quality connections with family when family cannot be present. We also believe that in ongoing health sector planning, rural issues must also be considered. The flexible approach historically needed within these settings was undermined by stringent infection control policies. Recreation team members play a significant role in contributing to long-term care residents' quality of life. Of course, they were not uniquely impacted by the pandemic, but their roles and work burdens seem to have been disproportionately impacted, and this deserves further examination and consideration. During a prolonged pandemic recovery period, residents and employee experience remain a very significant concern for the long-term care sector. Based on this research, prolonged pandemic measures are likely to contribute to ongoing work-related stress for staff and also have potential to affect resident quality of life. In ongoing health sector planning, the role of recreation team members is supporting resident quality of life should be carefully considered and articulated, including reflection on the nature of relationships with families, volunteers, and employees. We recommend consulting recreation team members and their managers directly. In this study, employees often spoke of general work experience such as burnout, communication, teamwork, and leadership. For more information on this topic, see our team's related posters presented on the An Inside Look and We Hear You project, or check out our living website and that shares employees' experiences. As I close, I'd like to acknowledge all of the dedicated staff participants who took the time to share their thoughts with me during the difficult situation of working in a pandemic. SHA directors Deanna Miller and Chris Thiel for inspiring and supporting this project, the participants of the long-term care homes from rural and northern Saskatchewan, SHRF for providing funding support, and team project members Katie Otley and Thomas Chow and Supervisor Paulette Hunter. Thank you everyone for listening to my presentation.
Thank you, Yash. This was a good presentation. I quite enjoyed to learn a lot about this work that you're doing. And I just want to ask, do you think that video conferences will continue to be utilized after the pandemic, considering the urgent need for it that we've witnessed right now through family and friends connecting with the residents, right? Just thought to collect your thoughts on that.
We think so. It definitely was. Certain forms of video conferencing, like phone calls, for example, were used all the time before the pandemic. And I think it definitely had a positive impact to have some sort of video conferencing as well. And it probably will, yeah.
Yeah. There's only positive comments in the, from our audience. Thank you so much, Yash. This was an excellent presentation. And I also wish you best of continuing your education and also in your early stages of your career. It's admirable to have someone who would like to connect their education with improving the health and well-being of Saskatchewan residents. Thank you. Thank you for all. I'll move on to our next presenter, Barb and Brenda, who will be presenting on patient-reported experience measure during COVID-19. Barb received a Health Information Management Diploma from SIAS Westana campus, now SAS Polytechnic, in 1997. Since then, her work in the healthcare system has largely focused on standardized data quality, practice data management, data analytics, and quality improvement. Throughout the pandemic, she has been working with the patient client experience, program support and development department of the Saskatchewan Health Authority. This opportunity has highlighted a relatively new realm of data collection and measurement for her, that being people-centered measurement and how understanding patient-reported experiences and outcome aligns with and can inform the strategic priorities of the healthcare system. Barb is both a patient and patient partner. She's a patient partner within the SHA as a member of the Patient Family Leadership Council, as a member of the People-Centered Measurement Working. She's also a chair of the Pan-Canadian Primary Integrated Healthcare Innovators Network Patient Advisory Council, which focuses on patient-oriented research through the CHR SCPOR, and is currently collaborating on the COVAR Research Project and the OECD Paris Project. Welcome, Barb, Brenda, over to you.
And Janica. Hello and welcome everybody. Full disclosure, I'm pretty excited to be here and I can hardly hear my heart beating because it's beating so loud. Welcome to the People-Centered Measurement Strategy Working Group's presentation of what we call the Experiences of Healthcare during COVID-19 survey, which we hope to have go live very shortly. I would like to begin by acknowledging the First Nations treaties 2, 4, 5, 6, 8, 10, and the homeland of the Métis first slide. I don't see the slides. Are they there?
Yeah.
Okay, thank you. The focus of the survey is to measure what matters to the people of Saskatchewan, to the patient. To do this, we are measuring both the patient-reported outcomes measures and the patient-reported experience measures. As the SHA moves forward with the recovery plan, we are still focusing on the overall strategic plan of embedding people-centered, integrated care through the lens of the networks. In other words, connected care, and to continue to building the trusting relationships with the people of Saskatchewan. We have been working collaboratively with our health partner organizations on this survey for the past year. The purpose of the survey is to measure the patient experience, to understand the impact of the pandemic on the quality of life and on the health status, to measure people's abilities to self-manage their conditions, and fourthly, to identify both barriers and enablers of the SHA to meet the needs of the people during the pandemic. Over to you, Janica.
Thank you, Brenda. My name is Janica Hoskins, and I'm the Manager of First Nations and Métis Relations with the Saskatchewan Health Authority. First Nation and Métis Relations involvement will ensure that data collection is designed with respect to cultural responsiveness and that the voice of First Nations and Métis people is heard. Moreover, this is an opportunity to begin to understand how to embed the principles of ownership, control, access, possession, known as OCAP, into this project. We will be doing everything possible to make sure those who participate will have access to the data and knowledge mobilization. The data and information generated through this project will help First Nations and Métis Relations and the SHA establish measurable goals to identify and close the gaps in health outcomes experienced by First Nations and Métis people in Saskatchewan. Next slide, please. Both the Truth and Reconciliation calls to action and the SHA commitment to truth and reconciliation are at the core of all the work that First Nations and Métis Health does, and our participation in this initiative does reflect that. As this SHA shifts towards people-centered measurement and learning health systems, First Nations and Métis Relations focus is on helping to develop health services that truly reflect the needs of our people and communities. As First Nations and Métis Relations gleans information from this initiative, it will help inform how we develop First Nations and Métis health governance structures. Next slide, please. The purpose of the people-centered measurement strategy is to build processes and mechanisms to inform all levels of health systems and to provide value to patient-centered care. We need to co-design a strategy that leads to a culture of ethical space where everyone's voice counts. Back to you, Barb.
Thanks, Janica, and thanks, Brenda. Next slide, please. Through many team discussions and reviews of people-centered measurement strategies, both nationally and internationally, our team determined what we thought were the key domains of quality to be captured in our work with respect to people-reported experience measures, PREMs, people-reported outcome measures, PROMs, and socio-demographics. These domains have been included in the healthcare experiences during COVID-19 survey, co-designed by this team. Next slide, please. Following a public experience survey conducted in September 2020, consultations were held with SHA leadership, where we heard clearly that these voices and themes will continue to play an integral role throughout the healthcare system recovery process. One of the recommendations that resulted from these discussions led to the development of the healthcare experiences during COVID-19 survey. The survey aligns with the strategic priorities of the healthcare system recovery plan and also supports health network development using an integrated people-centered care approach. This work will be based in part on the learning health system concepts of continuous improvement and learning, with a goal of embedding these stories into the organizational measurement framework. The learning health system transforms people's experiences and outcomes into knowledge that drives decision-making and improvements, a data to knowledge phase. It applies this knowledge translation to influence change management and quality improvement, a knowledge to practice phase, and generates procedures for data collection, data sharing, and application of data, a practice to data phase. Currently, no PREMS or PROM standards exist in our province, and this project serves as a people-centered measurement proof of concept, as well as a baseline of experience measures, which will be shared with leaders and communities to inform evidence-based best practices, to honor our commitment to truth and reconciliation, and to drive quality improvement across jurisdictions of health and well-being in Saskatchewan. This project will also help to create a foundation for the PCM team's collaboration with the Paris Initiative, an international survey of people living with chronic conditions. PARIS is an acronym for Patient-Reported Indicator Surveys. It focuses on primary healthcare and also aims to understand aspects such as access to healthcare, wait times, quality of life, pain, physical functioning, and psychological well-being of individuals living with chronic conditions. This is scheduled to pilot in early in 2022. Now I wonder if we could just go back to, we have an audio file with reflections from our people-centered measurement team on what it means to them to participate in the design of this strategy and the work.
Big business has gotten pretty good at understanding their customer needs, but in healthcare, we're just starting. Our PCM team is diverse, including patients, families, and multidisciplinary partners, and that's leading us down roads less traveled, resulting in innovation and a real opportunity to lead healthcare into understanding what matters to patients.
What brings me to the patient-centered measurement team is how we represent different health partner organizations with different lived experiences, and together, through our shared values and common narrative, we work together in co-production and co-design.
I'm excited to be part of this accomplished and inclusive people-centered measurement team. The meaningful and respectful engagement of patient partners like myself underscores the collaborative nature of this important work. Team members are committed to a common vision of capturing and better understanding what matters most to patients, families, and communities, and ensuring that people-reported experience and outcome measures drive health system transformation.
I really appreciate the opportunity to be part of the team that's working to create a channel for the patient and family voice to be heard and included in decisions that are made within the health authority. Healthcare works best when patients and families are equal partners in all aspects of care.
I'm so pleased to be participating in this initiative because I'm so hopeful that shifting the focus of health systems towards people-centered and integrated services will help improve health outcomes for First Nations and Métis people in Saskatchewan. This team has shown strong leadership and the establishment of a shared vision, including a commitment to honor the First Nations principles of ownership, control, access, and possession, also known as OCAP, in all the work that we're doing, which is so important to meaningful reconciliation.
I have great respect for the many backgrounds, skills, and viewpoints on the team. It has been a truly collaborative learning journey, and we are aiming to improve patient care by asking the patients. Working in patient-centered and community-engaged research is truly what's going to make significant differences in healthcare and across the health system.
I'm relatively new to Saskatchewan, and it's great to work on such a wide-reaching and meaningful project as an introduction to the Saskatchewan healthcare system and to so many great people from across the province who keep it all moving and flourishing.
Our people-centered measurement team is community-driven and is constantly working on finding ways to transform the health system with the voices of patients, families, and communities. It is a privilege, and I'm honored to be part of this team.
As a patient-oriented researcher from the University of Saskatchewan, I have been very encouraged by how this team champions patient-family voices and is working to support patient measurement in the learning health system.
I strongly believe that sustainable improvements can only happen if we understand the patient side of healthcare. I like being part of this group because we get to do it together.
I'm excited about being part of this work because I believe the only way we can improve the health system in a meaningful way is by understanding the needs of the people who use the system, and then allowing those voices to guide us in making improvements. The work this team is doing is the first step along that journey.
As a nurse practitioner and patient family-centered care specialist, I feel privileged to be able to contribute to this team. Our collaboration supports transformational health system change founded in evidence and continuous quality improvement. Experience-based metrics are reflective of our shared value of patient and family-centered care to achieve equitable, safe, and high-quality care.
I really like having the opportunity to learn more about non-traditional measurement and how patient experiences can be a catalyst for recognition, improvement, and action in our health system. I also really enjoy the diversity of our team and having a safe space to share thoughts and ask questions.
As a former patient family partner, I recognize the need for Indigenous voices at the table. And since being a part of the SHA, the value of having Indigenous patient partner voices at each patient partner engagement.
With that, I'd like to thank everybody on our team for contributing to the presentation, and special mentions to my co-presenters, Brenda and Janica, who took a lot of time and effort to help put together this presentation. And thank you to everybody for joining and listening in this morning. I'll turn it back over to you, Sandy.
Thank you so much, Barb. This was such a great presentation, and it was really nice to hear from the team. You know, it's hard, sometimes it's you don't get to capture everybody's perspective and thoughts, but this was really, really nice. It was different and I quite liked it. I enjoyed it. I just had one question before I asked one question from the audience, is that you mentioned the Paris survey. I was wondering whether this can be something that would be carried on in other years as well, or is this something that can be done in the pandemic? What are your thoughts in the group?
I can answer that one, Barb, if you like. The Paris survey, for those who don't know, is an international survey being done in 36 countries and is funded by Health Canada. And Saskatchewan is involved in the pilot phase of this project. And we're hoping that we will use this project, the Paris project, and the Health Experiences Survey to guide us in our strategies moving forward. And it will probably be about 5 years, I think, the study in total.
Thank you. I have one question here from Blake Hunter. She says it's great to see the collaborative work on people-centered measurement. I'm curious if this work extends to long-term care context and how it's being adapted to that context.
That is a great question, and I feel like she might be reading our minds. We've kind of started with what we've presented today, focusing on our primary health care and collecting that information for the development of the healthcare networks. And long-term care is kind of our next step in collecting experiences. And it aligns with the strategic priorities as well of the healthcare system. And so we've had some beginning discussions related to that, but we haven't taken that plunge into developing the next kind of prems and proms for the long-term care area, but that is next on our list, so to speak.
Much, Barb. Yeah, just positive comments from everyone, and thank you so much, and Brenda and Janica for the presentation. And for our group, we will just end our session here, but we will continue after a short break at 11:10. So take a short water break or just like a stretch, and then we'll be back shortly. And if you haven't done so, please go ahead and vote for our posters when you're able to in the poster hall. If you go under lobby, I think there's a link that you'll be able to do that. Thank you so much, and we'll see you shortly.